everyone. I am Dr. Ramesh, Professor and Head Cardiac Anesthesia Department at UN Mehta Institute of Cardiology and Research Center. Today we are going to discuss a very important topic, that is blood conservation during pediatric cardiac surgery. As we are having high volume of surgeries, we are doing 20 to 24 cardiac surgeries in a day. Out of that, 30% of the surgery are pediatric cardiac surgery. So meticulous use of blood as well as its conservation is very important during the cardiac surgery. So we are having important topic to discuss today, that is blood conservation during pediatric cardiac surgery. As we know, number of children undergoing complex cardiac surgery is increasing day by day. So blood transfusion as well as blood loss is very high, especially in pediatric patients. According to a study, out of 100 patients, 70 to 75% of children who underwent cardiac surgery, they receive blood either in the form of RBCs or in form of components of blood like FFP, platelet or cryoprecipitates. Of course, blood transfusion is not without risk. So there is a risk and clinical impact of blood transfusion always there. Risk like febrile reaction out of 1% of patients. Some patients may get blood transfusion related lung injury. So some patient may develop acute kidney injury, acute lung injury. All of these will create massive amount of adverse reactions. They will cause long duration of ICU stays, and ultimately they will develop lung injury and increase the burden on the hospital as well as ICU stay. So meticulous use of blood as well as blood conservation is very important. There are some challenges for blood conservation in pediatric cardiac age group. So children there are a unique set of changes pertaining to blood conservation during because of their have small blood volume and large priming volume in CPB circuit. So requirement of hematocrit is very high during CPB. So presence of cyanosis in some children, all of these reasons. So there are some challenges in blood conservation in pediatric cardiac surgery, especially pediatric age group. Of course, a congenital deficiency in some children or factors like 7, 8 or 1 Willebrand factor, they further increase the risk of bleeding and blood transfusion. Furthermore, some patients who are having systolic flow abnormality, they have platelet dysfunction, then patients who are having diastolic flow abnormality. And one more risk factor is that the patients who are exposed to extracorporeal circuit, which are non-endothelized and artificial circuit. So there is development of qualitative and quantitative platelet abnormalities, coagulation deficiencies and hypofibrinogenemia. We'll discuss blood conservation strategy in preoperative area, while during operation as well as in the postoperative area. So we'll divide the discussion in 3 parts: preoperative, intraoperative as well as postoperative. So what we can do in preoperative area? Number 1 is autologous blood transfusion. We can do autologous blood transfusion, blood collection, but it is possible when patient is over 3 years of age or patients who are having more than 15 kg of weight. Maximum we can withdraw about 10 ml per kg of blood via phlebotomy with central line or arterial line insertion, and it is replaced by 0.9% normal saline or colloid. This autologous blood we can store up to 3 weeks with CPDA solution and up to 6 weeks in cryopreservation. For small children, 3 to 4 week interval is always required for second donation, and last donation should be 1 week before the surgery. But after autologous blood donation, we have to do some medical management like erythropoietin therapy, which is but it is, of course, it is not out of risk. It has practically some cumbersome, and of course it will lead blood bank load on blood bank services, repeated visit to the blood bank, and cost of the treatment. So they recommended 100 to 300 unit of erythropoietin is required per kg subcutaneously in each donation. and maximum dose we can give 300 microgram per kilogram, and it is given 1 week before surgery. So this is one method for autologous blood transfusion. Second is erythropoietin therapy. Whenever patient is planned for surgery and patient is having some borderline hematocrit, then we can treat the patient with erythropoietin. The dose is 300 microgram per kilogram. Before 1 week of surgery, it is given by subcutaneous. Not only erythropoietin, but we have to give iron supplementation, vitamin C, vitamin A, K and folic acid, and vitamin B supplementation is always necessary along with erythropoietin therapy. Erythropoietin therapy is not out of risk. It always have some kind of risk like hypertension or flu-like symptoms may develop. Now what we can do peroperative, intraoperative for blood conservation in pediatric cardiac surgery. So monitoring lines and sampling volume, close blood conservation. While taking a central line or arterial line, avoid repeat attempts at the same time, at the same site. Always, whenever we cannot get central line at one place, then always try to change the site or change the hand, or whenever there is arterial line puncture occurs, so prompt compression of the puncture site should be done. So this is limiting the frequent flushing of invasive lines is also helpful to prevent hemodilution whenever desirable, and always sampling volume should be less than 1 ml to conserve blood. A recent clinical analyzer may provide an arterial blood analysis with as little as 3 drops of blood is sufficient to analyze the blood for arterial blood gas analysis. In right side figure, there is a double stopcock technique. We can use with the help of this technique, we can prevent hemodilution and blood loss while taking sampling. So always we follow this double stopcock technique while taking sampling for arterial blood gas analysis. And second is acute normovolemic hemodilution. What we can do, there is no general guidelines for acute normovolemic hemodilution, but before initiation of acute normovolemic hemodialysis, it is mandatory that patient should have more than 30% of hematocrit and the blood may be withdrawn using an arterial line or central line. Maximum we can withdraw 10 to 15% of blood volume, and which is replaced by crystalloid or colloid. While taking this autologous blood volume, always monitor standard monitoring like ECG, saturation, blood pressure monitoring and other hemodynamic monitoring. Adding on that, NIRS monitoring is very, very important while taking acute normovolemic hemodilution. While reinfusion of blood which is given to the patient, it is always CPDA collected bag. So always give calcium gluconate after infusion of this autologous hemodiluted blood. There are some antifibrinolytics available in the market like aprotinine, tranexamic acid and epsilon aminocaproic acid. They help in preventing blood loss. So they always we in our institute we use tranexamic acid 10 milligram per kilogram just before incision, and after completion of the protamine, after completion of the surgery, after completion of the protamine, we give another dose of 10 milligram per kilogram tranexamic acid to prevent blood loss and conserve blood. So it is recommended to use either tranexamic acid, epsilon aminocaproic acid or aprotinine in cardiac surgery to prevent blood loss. Then another is retrograde autologous priming. In this technique, first of all aortic cannulation is done, then as shown in right side figure, aortic cannulation is done, then CPB circuit is filled retrogradely with this aortic cannulated blood, oxygenated blood, and half of the prime solution which is present in the circuit, it is collected in collection bag. So 50% of the prime solution is removed, and whole circuit is filled with retrograde autologous blood. Maximum we can withdraw 50% of this blood, and by doing this, displacing 50% of prime volume with retrograde autologous priming. If it is not done, then 75% of hemodilution will occur. So this technique is also very, very important. To counteract the transient fall in mean arterial pressure, we may sometime use phenylephrine to maintain hemodynamics. And miniaturize of the circuit. Basically, this is modified and dwarfed version of conventional CPB circuit. What we can do, we can decrease the size of arterial cannula, we can reduce the size of venous cannula. By creating this, we can minimize the exposure of blood to the artificial surface, that will prevent inflammatory reaction, as well as that it will prevent hemodilution and prevent blood loss. And microplasia, actually microplasia is a type of blood cardioplasia. To deliver microplasia, blood is diverted from the arterial line and then oxygenated through roller pump. And cardioplasia with high potassium content up to 40 to 100 milliequivalent per liter, it is delivered in the blood by a syringe pump. So there is a ratio of 1 part of cardioplasia and 60 part of blood. So what will, how can it help? Then microplasia will prevent hemodilution, especially in repeated delivery of cardioplasia. It will decrease the tendency of tissue edema. It provides better myocardial protection, higher oxygen delivery, higher hemoglobin, and negligible fluid balance of cardioplasia. The advantage of microplasia have not been studied exclusively, but we are using microplasia in pediatric cardiac surgery. And dose of the microplasia is loading is up to 30 ml per kg and maintenance dose is 5 to 10 ml per kg. Ultrafiltration. This is very good device which is having filtration membrane. So it basically eliminates inflammatory mediators generated during CPB, and plasma proteins and platelets are preserved during ultrafiltration. So basically ultrafiltration will remove excessive water, debris, inflammatory mediators. So by doing ultrafiltration, we can improve hematocrit, improve hemostasis, decrease blood loss and transfusion. Basically there are two types of ultrafiltration, conventional ultrafiltration and modified ultrafiltration. Conventional filtration we can do during the CPB, patient is on CPB. It is continuous process, and modified ultrafiltration we can do after coming off the bypass. So both the things are different. Better to do modified ultrafiltration. It is better. It will give better hematocrit and blood pressure, and which are infants undergoing arterial switch operation. Vacuum assist venous drainage. In right side figure, this is the graphical representation of vacuum assisted venous drainage. But for that matter, we need to use hard shell reservoir. In hard shell reservoirs, there is vacuum is created. It is attached with the vacuum pump. Always keep in mind that vacuum pressure should not be more than minus 40 millimeter of mercury, because whenever there is increase in negative pressure, there will be creation of bubbles and hematuria will occur. So it is essential component of microcirculatory whenever used in pediatric CPB. So vacuum assisted venous drainage return may be increased by as much as 40%. So it is very good method, especially when we use microcirculatory use in pediatric cardiac surgery. Sometime hemolysis may occur, but we have to keep watch on negative pressures, which should not be more than 40 millimeter of mercury. There is safety valve in this negative pressure system, so it will always give a reminder and make us alert whenever there is more than 40 millimeter of mercury pressure. This is surface modified bypass circuit. To prevent blood loss, to prevent inflammatory reaction, there are some components which are available for modification of the circuit, for coating of the circuit. Which are the components? We can modify the circuit with the help of heparin, with trillium, with phosphorylcholine and sancoeternal. These are the components for helping. With the help of this component, we can coat the circuit, bypass circuit, so it will help in prevention of inflammatory reaction. So currently available literature, it cannot be established that surface modified CPB circuit decrease bleeding postoperatively, but indirectly it will help in another way, like serum level of inflammatory cytokines and molecules will reduce. So it will help in another way. Cell saving devices. In right side upper corner there is cell saving devices that we are using in some redo surgeries or patients who are having very much high volume of oozing. So basically principle of this machine is that the machine will collect the ooze sterile blood. The machine will centrifuge it and wash it with saline, and we can reinfuse this RBC again to the patient. So basic work is removal of coagulation factor, platelet and plasma proteins are also removed. So only RBC we can infuse with the help of this cell saver device, but it is very helpful device in conservation of blood. And special coagulators are available like ultra incision harmonic scalpel. It will cut and coagulate at the same time. So by doing this, indirectly it will help in preservation of blood and blood loss. With the help of these special coagulators, we can speed up the surgery by 31%. Operative time will reduce by 31%. Blood loss will reduce by 45 ml and cost saving by 10%. So it is very helpful device. And topical hemostasis agents are available in the market like fibrin sealant, absorbable sponge, oxidized generated cellulose, gelatin thrombin, microporous polysaccharide, chitin and chitosan based agents. These are some of them are liquid, some of them are semi-liquid, or some of them are in sponge-like form. We can apply on the raw area or raw surface, so they will seal the surface and it will help in preserve blood and loss of blood. So it is very helpful in pediatric cardiac surgery. Some tests are available. We can do it, name it point of care test. With the help of this test, we can exactly know the reason of the bleeding. We can exactly know the platelet function is either qualitative or quantitative dysfunction. We can exactly know which factor is required for the patient to stop the bleeding. So these tests are ACT, platelet counts, fibrinogen level, prothrombin time, APTT and international normalized ratio. Some vasoelastic tests are available like thromboelastography, sonoclot and rotational thromboelastometry, and qualitative platelet function test is also available. With the help of this vasoelastic test, we can exactly know which component of the patient is required for the patient to stop the bleed. So we can exactly know the quantitative or qualitative dysfunction of the platelet, and we can transfuse the blood components accordingly. This is the picture of rotem and sonoclot. We can this is the picture of machine, and we can get graphical representation of the sample. This is the picture of qualitative platelet function test. By help of this machine, we can exactly know the platelet qualitative or quantitative dysfunction of the platelet. This is the transfusion algorithm. Like if PT is more than 1.5 times of the control, then we can transfuse FFP 10 to 15 ml per kilogram. If APTT is more than 2 times than the control, then FFP 10 to 15 ml per kg we can transfuse. If platelet is less than 50,000, then platelet is required 10 ml per kg. And if fibrinogen less than 0.8 to 1 gram per liter, then cryoprecipitation is required. It is requirement is 1 unit per 10 kilogram. To prevent dilution coagulopathy, it is recommended that transfuse RBC with plasma in ratio of 1:1. Then this is transfusion trigger. Basically, there is no cutoff value of transfusion trigger. Some centers recommended 24-25 hematocrit on pump, and some centers recommended 30-32 hematocrit while patient is on pump. But restrictive transfusion strategy is safe under strict monitoring and end organ oxygenation parameters. And liberal transfusion strategy is not associated with increase in MODS or life-threatening complication. Our goal is to keep hematocrit around 30 to 35%. it is achieved by blood conservation rather than blood transfusion whenever possible. This is another very, very important component, that is recombinant factor 7A. It is very, very helpful when the patient is having very refractory hemorrhage. So before administration of recombinant factor 7A, the platelet count should be at least around 50,000 per microliter, and any consumption coagulopathy should be ruled out. And one more contraindication for transfusion of recombinant factor 7A is that patients should not have disseminated intravascular coagulation. So due to risk of thrombosis, the routine use of factor 7A cannot be recommended to control operative bleeding in pediatric cardiac surgery, but it is preserved drug, and it is only should be used in refractory hemorrhage. In children, the dose is 70 to 87 microgram per kilogram. It will reduce the postoperative bleeding as well as blood transfusion. And what we can do in postoperative area? In postoperative area, in infant and children, avoid repeated sampling to prevent hemodilution. So in comparison to older children and adults, they have small circulating blood volume in the children. So therefore, repeated blood sampling and investigation should be restricted to significant amount of blood loss volume. So flushing of the monitoring with heparinized saline, it is always cause hemodilution. So reduction in the total number of tests as per patient requirement, and repeated flushing should be avoided. So in conclusion, what are the strategies to conserve the blood in pediatric cardiac surgery? So in preoperative area, we can do autologous blood transfusion, and with the help of erythropoietin therapy, those patients who are having a very borderline hematocrit. In intraoperative area, monitoring lines and sampling volume, always change hand if difficulty in finding central line or artery line. Then acute normovolemic hemodilution, antifibrinolytics, retrograde autologous priming, miniature of the circuit, microplasia, ultrafiltration, vacuum assisted venous drainage, surface modified bypass circuit, cell saving devices, special coagulators we can use, and we can use topical hemostatic agent. And what we can do in postoperative area, we can take the help of point of care test and transfuse the blood or blood component accordingly. We can use antifibrinolytics like aprotinin. We can use recombinant factor 7A in refractory bleeding, and always reduce blood sampling and repeated flushing lines in postoperative area. So with the help of these all strategies, definitely we can conserve blood in pediatric cardiac surgery. I think this is very important, and it is very useful if we remember these strategies. Thank you very much. Thank you.